Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaj. Let's bring a paradigm shift in the way we conduct the live mock test discussion. So everything is now hand-sketched infographic review of at least 10 points for every MCQ in the mock test. A 45-year-old diabetic febrile patient with hemoptysis, pleuritic chest pain, and weight loss. You need to think of invasive aspergillosis. What is the morphology of aspergillus, doctor? The branching angle is 45 degrees. And the aspergillus colony typically is a blue-green powdery colony. Halo sign, which is very typical, is an early CT finding, and there'll be a crescent of air which will be surrounding this nodule during the later stage, which is called the air crescent sign is what we need to remember. So who are the subset who is vulnerable to the aspergillosis, doc? Neutropenics, those who have diabetes with steroid therapy typically. And if you look at the other fungi, favorite MCQ in exam, mucor. Mucor is broad, mucor is aseptate, mucor is right angle branching. You should remember. Aspergillus is notorious to lead to a angio invasion. It will invade the blood vessels, which is the key feature of aspergillus. So what is the gold standard test? We do a test called galactomenon antigen test, which is considered to be the gold standard. And what is the drug of choice, doctor? Oriconazole is the drug of choice. So whenever there is any hemoptysis, pleuritic pain, weight loss, the classic triad, you need to think of the possibility of a aspergillosis, especially in a neutropenic or a diabetic individual, is what we need to remember. Now the second question. 28-year-old woman with severe pelvic pain and hemodynamic instability after a high energy trauma. It's called open book pelvic fracture. So if you look at the pelvic ring, there is one anterior ring, posterior ring. And open book injury means the sacroiliac joint is widened and there is a diastasis is what we need to remember. Whereas closed means lateral compression is called the closed book injury. So every MCQ is based on a PYQ and every MCQ will give 10 points you need to crisply remember for the next upcoming exam. That is the philosophy behind the 30 full-scale NEETPG mock tests, which give you 6,000 MCQs, and each MCQ is followed by 10 possible things that you need to remember for the tomorrow's NEETPG exam. A patient is having nasogastric tube presence with before enteral feeding. In the image, which was actually the clinical image given to you on the mock test, what is the next important step? The proximal port is above the diaphragm in the thorax and the distal tip is in the stomach. So the side ports must be below the diaphragm before feeding. It is very important. That's the reason you need to advance the tube and reconfirm the position before feeding. So if the port is above diaphragm, there is a risk of pleural injury. Pneumothorax is what we need to basically remember. So that is the fundamental thing in this particular question. There is an atrial fibrillation, a patient with sudden severe abdominal pain for 3 hours. When you look and check this image, what you are able to see? You're able to see acute mesenteric ischemia because of an arterial embolism. That's very important, right? portal venous gas, pneumatosis intestinalis, they all happen when the bowel become gangrenous and lead to the release of the gas forming organisms growth, like Clostridia, is what we need to remember. So what is the most common cause of the acute mesenteric ischemia, doctor? You should remember arterial embolus is the one which we need to basically remember. Very good. Nice to see around 4 of the classmates who are all online. Good. So nice to see Dave and many more who are all online. Good. So what is the classic presentation? Any sudden severe disproportionate abdominal pain is an important clue to say that it is a mesenteric ischemia. Whenever there is any atrial fibrillation that can lead to systemic embolization, which can lead to development of mesenteric ischemia. Elderly people, the atherosclerosis can cause the narrowing of the blood vessels, leading to the development of ischemia. So always the first step is intravenous unfractionated heparin need to be given immediately is what you need to basically remember. The remaining 10 points you try to remember and revise along with your friends. Hand sketched, illustrated, mind map, infographics. For every mock test, you get the booklet of PDF, and that will help you to pictorially remember and revise very easily. Right now, there's an atrial fibrillation, a patient with severe abdominal pain. So how do you want to treat? Once more, IV unfractionated heparin. So you need to know a few things about what is meant by the double bubble sign whenever there is any duodenal atresia, duodenal obstruction, right? And commonly duodenal atresia is associated with Down syndrome is what you need to remember. And how does duodenal obstruction, atresia present? There is a bilious vomiting, abdominal distension, no stool being passed, classically is the feature. So double bubble sign, one is stomach, other is the gas in the duodenum, is the classical feature, and you must know the differential diagnosis. Now, a laboring multigravida woman with cervical dilatation of 6 centimeters and inadequate descent, the image being given. So, what does it basically suggest? This suggests the contractions are adequate. No need to augment. Any adequate contraction is more than 200 MVU is what you need to basically remember. Montevideo units, right? So based on this, there is no need for augmenting this labor. So the sum of the peak and baseline over 10 minutes is the Montevideo units. When do you call adequate contractions of the uterus? More than 200 Montevideo units is what we need to remember. And tachysystole, when there are more than 5 contractions in 10 minutes, often more than 90 seconds in duration, then you need to stop the oxytocin, and if required, you need to initiate a uterine relaxant. Tocolytic need to be given. Any high resting tone, abnormal baseline, more than 20 millimeters of mercury, you need to stop the oxytocin. Tocolysis, fluids, left lateral position is very important. And normal baseline is typically more than 15 millimeters of mercury is what we have to basically remember. So that is all about the uterus, the contractions, etc. Now, doctor, 35-year-old female with progressive hoarseness of the voice, fatigue for months. You are able to see on examination bilateral, symmetrical, translucent, gelatinous swelling of the vocal cords. This is called Rinke's edema. Chronic smoking is the most common cause for the Rinke's edema. The typical voice will be deep, low-pitched with the hoarseness. But if you look at the vocal cord mobility, it will be normal in Rinke's. Important differential diagnosis for the hoarseness will be unilateral polyp. And why not vocal nodule? Vocal nodule will be bilateral nodule at the junction of anterior 1/3 and middle 1/3. Favorite question. What is the most common location? So these are few things you need to remember in perspective of this PYQ. Now, a 7-year-old child presents with a pruritic bullous eruption, abdominal pain, arthralgia. So there is a subepidermal blister with neutrophils in papillary tips, which is very classical. And direct immunofluorescence is showing granular IgA deposits in the dermal papillae. So any intensely pruritic grouped vesicles with IgA at dermal papillae is equal to dermatitis herpetiformis, is what we need to basically remember. Then gluten sensitivity, most common association with dermatitis herpetiformis. There will be neutrophils in the dermal papillae, and it is the tissue transglutaminase 3 autoantibodies, IgG type, which are very important. There is a linear IgA deposition along the basement membrane zone, which is very classical. So children and young adults are very classical. And how do you treat? Gluten-free diet, and dapsone is the first line treatment. Favorite MCQ. And if you initiate dapsone, the pruritus will improve rapidly. Rapid relief of pruritus will be there. And what are the other blistering diseases? One is linear IgA disease and epidermolysis bullosus. So how do you differentiate them? Mainly by immunofluorescence. That's what we need to remember. So good to see. In each answer, tell us how to rule out other options. Why not other options? Good. See, there are very few scenarios like acid-base disturbances or other tricky things. Whereas 80% questions are factual when you come to the NEETPG exam. The characteristic feature which points to the diagnosis, you need to catch that. So that is most important, right? For example, photosensitive rash, muscle weakness is present, and violaceous papules on the metacarpophalangeal and interphalangeal joint is typically the Gottron's papules. There is no other differential diagnosis here. It is typically dermatomyositis where there is a symmetric involvement. So heliotrope rash, Gottron's papules on the MCP and IP, interphalangeal joint. Photosensitivity, Proximal muscle weakness, they can't get up from the floor. See, always neuropathies lead to distal myopathy and distal myopathy, whereas myopathies are small, proximal muscle weakness. And if you happen to check in them, CPK levels will be significantly high, which is an important clue. And anti-Jovan antibody is the common antibody you need to remember when it comes to the dermatomyositis. There's an increased risk of malignancy. Granular immunoglobulin G and complement C3 deposition in the dermis is a very important clue. And we need to give high dose steroids. And what are the skin signs in dermatomyositis, doctor? Malar rash, photosensitivity is very classical. Why not polymyositis? There are no skin findings in polymyositis. Why not rheumatoid arthritis? Erosions, rheumatoid factor positivity, joint disease. So it is the skin signs which point towards the dermatomyositis is what we need to remember. A middle-aged man presents with a sudden painless loss of vision in one eye. It is vitreous hemorrhage. So the red reflex is absent. The fundus view obscured by the diffuse red haze and painless sudden vision loss, they are the important features. So the red reflex of the fundus is absent. The fundus view is obscured by all that haze caused by the bleeding into the vitreous. What are the common causes that lead to bleeding into vitreous duct? Diabetic retinopathy, peripheral vascular disease, any retinal tears, trauma, they are all the causes. Most common is diabetic retinopathy. So any painless, suppose if it is retinal detachment, painless sudden flashes and floaters is equal to retinal detachment. If it is central retinal artery occlusion, it is cherry red spot. If it is a painful eye with hypopyon, think of endophthalmitis. And if you look at the pupil in vitreous hemorrhage, it is usually normal. If you look at the intraocular pressure in vitreous hemorrhage, usually normal or decreased. That is another important clue. So how do you manage the vitreous hemorrhage, doctor? Treat the underlying cause, give bed rest, give head elevation, avoid NSAIDs, which predispose to bleeding. If it is not clearing, then we need to do vitrectomy is what we need to remember. So, very good. What is red reflex, sir? Good question. You throw light and it will throw redness. Simple. Red reflex में magic क्या होता है? नाम ही बोल रहे. Red reflex, right? Yeah. So best medicine says, I should not read each option and not get confused. See, I'll tell you, doctor. आजकल इंटरनेट में बहुत स्टोरीज बनाते, how to rule out the options, how to do crash revision. ये 20 क्वेश्चंस पढ़े तो तुम पास हो जाओगे. There's nothing like that. If every condition will have 5 to 6 characteristic things that the examiner will ask in every entrance. For example, if you take SIADH, syndrome of inappropriate ADH secretion, the urinary sodium is high, plasma sodium is low, and the urinary osmolarity is high, and plasma osmolarity is low, and the urinary sodium is more than 20 milliequivalents. So this constitutes the diagnosis of SAIDH. If you know what is this combination, straight your answer will go and hit SAIDH. Like that. What you need to know in NEETPG exam is examiner has a set of 10 characteristic things. For example, diabetes insipidus is a diuretic state. Still, thiazide diuretic is the drug of choice. That is what every examiner will ask the same question. Hypertrophic obstructive cardiomyopathy में angina होता है मगर nitrates नको देना क्योंकि nitrates are vasodilators, they decrease the preload, they will make the left ventricle become smaller in size and that will cause the touching between anterior mitral valve leaflet and the interventricular septum very touching and obstruction worsens, angina worsens. HOCM बोलते ही आपको याद रखने का पॉइंट यही होता है. Any sudden cardiac death in athlete, immediately what examiner is asking? Either mitral valve prolapse or HOCM. Like that. Every high yield topic का एक 20 points रहता है जो उसका life होता है. It is the life of the topic. इतना बड़ा हैरिसन पढ़े, उतना वीडियो देखे, मगर वो 20 पॉइंट्स को अगर नहीं पकड़े तो मेरे यार exam become difficult. So in exam there is no thinking, there is no ruling out. It is not like a clinical medicine. In clinical medicine only we are not really using our brain, we are using spinal cord. Patient while walking only we know that what is the problem. Does he have diabetic neuropathy or does he have Parkinsonism? So your practice should be so focused, so precise that you should know what are those 20 points for 840 topics, right? So there is nothing like ruling out, how to eliminate the options. ये सब YouTube और Instagram का titles के लिए बहुत अच्छा लगेगा, right? You're with me? Good. So doctor, good Devang. Now, young man with progressively enlarging firm pleuritic scar after ear piercing. The image is being given. So this is a typical keloid. In keloid, what do you do, doc? Interlesional triamcinolone is considered to be the treatment of choice. And thick hyalinized collagen, low cellularity, episode arrangement. So what is the staining used to detect all that? It is the Mason's trichrome which is being used. So how do you differentiate hypertrophic scar from keloid histologically? It is less cellular, extends beyond the wound in keloid is what you have to basically remember. So keloid is low cellularity, thick collagen, extends beyond the margin. And the first line treatment is intralesional triamcinolone is what we need to remember. An adult is having new focal seizures. Subtle cognitive decline is present. What is your diagnosis, doctor? It is periventricular nodular heterotopia, multiple gray matter nodules along the walls of the lateral ventricles is the classical appearance. So I leave few important histological features, differential diagnosis and what are the characteristic points, 10 points that you need to basically remember. Now, doctor, reproductive age women with gradual abdominal enlargement and pelvic mass over months. Looking at the image, large multilocular cyst with smooth external surface, thin septations filled with thick mucinous material, usually benign and disease. Mucinous cyst adenoma is what you need to basically remember. So it has got solid components, hair, sebaceous material. CA19-9 is the tumor marker, and typically it originates from surface epithelium, coelomic epithelium. Dark brown chocolate fluid typically seen in endometrioma. If it is mature cystic teratoma, solid components, hair, sebaceous material will be there. And what is a very common complication of a teratoma? It can undergo torsion. The mucinous cystadenoma. So, reproductive age women, large pelvic mass, multilocular cyst, thick mucinous material, smooth external surface, the diagnosis is mucinous cystadenoma is what we need to remember. 45-year-old male with fever, jaundice, right upper quadrant pain. What is your diagnosis, doctor, when you look at it? It is Mirizzi syndrome. Whenever there's an impacted stone in the neck of the gallbladder or Hartmann's pouch, we call Mirizzi syndrome. There's an extrinsic compression of common hepatic duct. It leads to obstructive jaundice, cholangitis is what we need to basically remember. So the impaction of the gallstone in the Hartmann's pouch causing an extrinsic compression of the common hepatic duct is what we need to basically remember. Then what is Charcot's triad? Whenever there is a cholangitis, that is inflammation of the bile ducts, you get pain, fever, and jaundice, which is the classical clinical triad. Now, doctor, a 65-year-old man, sudden lower limb weakness, loss of pain and temperature below T6. So, if you look at this, there is no fever. If fever would have been there, then we would have thought it as transverse myelitis. He's an elderly man. There is an infarct in the anterior 2/3 of the spinal cord, usually anterospinal artery. It affects corticospinal tract, the descending one, and the spinothalamic tract, ascending one, carrying pain and temperature. Whereas the dorsal columns that carry the vibration and touch, they are spared. And classically at the thoracic level, T4 to T8, it is the artery of Adamkiewicz, which is basically abnormal. So if you look at the spinal cord, it is the anterospinal artery, anterior 2/3 is what we need to basically remember. So I leave the literature for you in the PDF containing all the 200 questions, 200 pages PDF, which will give you 10 points on each of these as a hand-sketched infographic, visual, illustrated images that will make your memory strong and stronger. Now, doctor, an adult presented after suspected electrical injury with a transient loss of consciousness and limb pain. So there is a small eschar entry wound. This is an electrical injury. Treat the patient, not the wound, is what you need to remember. So small entry and the exit, which is large and charred wound, is characteristic feature of electrical injury. Small entry, but जब बाहर निकलता है, that wound is exit is large and charred. It can lead to cardiac arrhythmias, ventricular fibrillation. You need to do ECG and continuous monitoring. And you need to look for CPK, serum potassium, myoglobin, because all the deep tissue injury will lead to the development of myoglobinuria, and renal shutdown is what you need to basically remember. Postpartum women with fecal soiling and perineal defect. So a third degree perineal injury, it involves perineal muscles plus external anal sphincter. The rectal mucosa is intact. And fourth degree rectal mucosa is also involved. And commonly it leads to fecal incontinence is what we need to basically remember. So when will you repair, doctor? It is immediately within 24 hours after the injury or delivery you need to repair. You need to do end-to-end approximation. So they are the key things which need to be remembered. Perineal tear is a favorite question of the examiner. Elderly man with unilateral chewing difficulty and jaw deviation over several months. So the jaw muscles are typically supplied by trigeminal. So wasting of temporalis, loss of mandibular elevation, the jaw deviates towards the weak side of opening. So these are all the features that suggest you of trigeminal motor neuropathy is what you need to remember. So what is the nerve supply to temporalis, doctor? It is the mandibular division of the trigeminal nerve, and the jaw deviates ipsilateral to the side where the trigeminal is injured. Please don't forget, one of the favorite questions of the examiner. Now, patient has chest pain, hypotension. So, it is a case of inferior wall MI with ST elevation S1 to V1 to V3, where you have RV infarction. It presents with hypotension, raised JVP, clear lungs. If it is left coronary artery, anterior wall involvement, then the patient can land, whenever the left ventricle is affected, then he will land in the pulmonary edema. Whereas in inferior wall MI, the lungs are clear and all the signs of the RV failure will be there. And there the management is to improve the preload, not to give diuretics. That is very, very important. Now, doctor, patient has clinical and laboratory findings which are being given where hypersegmented neutrophil is there, which is classical of vitamin B12 deficiency. You need to treat it by giving vitamin B12. 45-year-old with painless breast lump and bloody nipple discharge. It is cribriform ductal carcinoma in situ, no stromal invasion, intact myoepithelial layer, distended ducts filled with uniform epithelial proliferation, forming a cribriform appearance is the histological feature, is what we need to remember. A middle-aged woman on long-term antipsychotics with involuntary oral movements. Classically, it is the tardive dyskinesia. Whenever there is a chronic dopamine D2 receptor blockade, there is a supersensitivity of the dopamine in the basal ganglia. It typically occurs after a few months to years of antipsychotic use. That is the point you need to remember. Right, doc? Now, a 45-year-old woman with solitary thyroid nodule, recent hoarseness, undergoes evaluation. So what do you see here, doctor? Papillary thyroid carcinoma. Any solid hypoechoic nodule with irregular margins. It is suspicious of malignancy, is what you need to remember. Which nodules are more malignant? It is the cold nodules, where radionuclide uptake is less, they're more malignant. And cervical lymphadenopathy is the feature of the papillary thyroid cancer, is what you need to remember. And what is the treatment, doctor? We do total thyroidectomy plus or minus central neck dissection is considered to be the management of choice. A diabetic patient presents with chronic foot lesion as what you are able to see here. So what is the next important step? So it is a neuropathic plantar ulcer with surrounding callus. You need to offload it and debride it is considered to be the management of choice. So 30 full-scale MoCK tests, doctor. So good to see 8 online classmates. Sir, if anyone starting now for this year, NEETPG is possible to crack and how to, if possible? Good question. See, the question is, there are 840 topics, doctor. Out of that 400 topics, almost 90% question paper is covered. So we created 20 PDFs, each with around 400 to 500 infographics, hand-sketched, illustrated, which cover the key points essential for you to become the winner. Right? So, master the 20 subjects, 20 because gynecology, obstetrics, if you treat them as 2 separate subjects. 20 PDFs are there. Today only you order them and they all contain infographics like this, hand-sketched, visual memory, which is more powerful than the video listening, face-to-face class, etc. 2-3 दोस्त के साथ बैठो और फटाफट each PDF खत्म करो. Each subject will have around 400 pages containing the key points that you need to master and active recall and spaced repetition you need to do. But that is the secret to become the winner. Right, Doc? Now, 55-year-old diabetic using inhalational steroids typically developed oral candidiasis, candida albicans. The patient with nephrotic range proteinuria and hematuria. Actually, here the histological slide is different. Tram track appearance is the classical feature which you see in membranoproliferative glomerulonephritis. Right? So if you do kidney biopsy, you can be able to appreciate the tram track appearance in case of the MPGN. Right? Between type 1 type 2, type 1 is most common. There is an endocapillary proliferation plus GBM duplication giving rise to tram track appearance, which is very classical feature of MPGN. 28-year-old with bleeding gums and fever, acute promyelocytic leukemia, where the OR rods are the very characteristic feature, otherwise called fagot cell, abnormal promyelocytes with OR rods. It is T1517 PML RARA fusion, which is very classical. And how do you treat, doctor? Arsenic trioxide and ATRA are considered to be very important in the treatment. Middle-aged diabetic with sudden painful swollen foot and necrotic ulcer. It requires urgent surgical debridement. Middle-aged obese diabetic with chronic transaminase elevation. Metabolic syndrome is there. It is an example of NASH, non-alcoholic steatohepatitis. In a cohort with variable percentile, if you convert incidence density to 5-year cumulative risk, what is the nearest value? So for that, you need to know cumulative index is 1 minus e to the power of minus IR into T. So if you do calculation, it comes to be around 9.5%. So what is incidence rate? Number of cases by total person time, right? So that's how you solve this question. In a superficial pin tract infection with stable traction, no systemic signs, what is the next antibiotic duration, doctor? If there is a mild redness and drainage around the pin site without a deep infection, then it is superficial pin tract, and oral antibiotics for 5 to 7 days is considered to be the management. A long-standing diabetic with absent nocturnal tumescence has erectile dysfunction. What is the underlying cause? Diabetes leading to veno-occlusive disease due to endothelial injury, corporal smooth muscle fibrosis is what we need to remember. What is the optimal time of emergency chest tube insertion to avoid intercostal neuromuscular bundle injury, doctor? It is mid-axillary in the 5th intercostal space, and you insert just above the upper border of the lower rib to avoid the neurovascular bundle, because the neurovascular bundle will be passing along the lower border of the rib. That's the reason. Adult with nephrotic syndrome suddenly develops unilateral flank pain and gross hematuria. Always FSGS, membranous nephropathy, diabetic nephropathy, minimal change disease, they are the causes of the nephrotic syndrome is what we need to basically remember. How to differentiate ICA from PICA? So, ICA, the facial nerve, which is facial nerve 7, in the pons is typically affected in ICA. Whereas PICA is lateral part of the medulla. So there you have tail nerve 9, 10 and all. So vertigo, nystagmus, ataxia, they are all the features in case of the posterior inferior cerebellar artery occlusion. In the DKA, when the serum potassium is 3.0, what is the immediate management priority, doctor, before you start insulin? Always remember, those who have diabetic ketoacidosis, even though their total body potassium is low, all that is outside the cell due to insulin deficiency. That's the reason, even though potassium 3.0 is normal, the moment you give insulin, it will suddenly fall down. That's the reason you need to give IV potassium either after starting the insulin, or if insulin is already low, before starting the insulin is what we have to basically remember. Patient with cirrhosis has periumbilical varices and Doppler shows flow directed away from the umbilicus. What is the common source? It is the periumbilical varices portal system. Periumbilical means the flow away from the umbilicus. The most common cause is portal hypertension. Whereas SVC obstruction, they flow towards the umbilicus. That is the differential between the two. In a bronchiectasis, massive hemoptysis, how do you control that? You need to occlude the bronchial arteries, which are responsible for 90% of massive hemoptysis in bronchiectasis, is what we need to remember. If a mycobacterial isolate is niacin negative and grows on pyruvate, then it is Mycobacterium bovis, which has an intrinsic resistance to pyrazinamide. So you need to remove the pyrazinamide from rifampicin, isoniazid, pyrazinamide, ethambutol regime, you need to remove the pyrazinamide if it is Mycobacterium bovis. And how do you recognize it? Typically, niacin test. Niacin negative, growing on pyruvate, equal to Mycobacterium bovis is what we need to remember. If the pretest probability is 30% and the likelihood ratio is 5, how do you compute the approximate post-test probability after positive result? What is the percentage? So pretest probability to odds. Odds is equal to P by 1 minus P. So here it is 0.30 into 1 minus 0.30, and you multiply with likelihood ratio. That's how you basically calculate the post-test probability. Okay. Now, we'll take a quick 5-minute break, doctor. So, welcome back to the session, Doctor. What is the mechanism for microcytic anemia with ringed sideroblast in a patient on INH therapy? It is typically ALA synthetase deficiency because we require pyridoxine as a cofactor for the ALA synthase, and INH lead to pyridoxine deficiency, leading to sideroblastic anemia is what you need to remember. A neonate with meningitis with listeria, what is the responsible factor? Listeriolysin. No, it is actin polymerization, ACT-A. So listeria basically escape the phagocytic injury by producing listeriolysin O, right? And it induces the actin polymerization and enable it to pass cell to cell spread is what we have to remember. 8-month-old with lower knees on flexion and limited abduction likely shows on a AP pelvic radiograph a broken Shenton's line, which is very classical. So all the radiological features, Shenton's line and acetabular index, you need to be doubly sure about that. A child is submerged in icy water. 20 minutes later, regains with intact neurofunction. So what explains this paradoxical survival? There is something called mammalian diving reflex. Child in icy water, trigger cold water on the face. Mammalian diving reflex lead to increased vagal activity leading to bradycardia and peripheral vasoconstriction. And the cerebral blood flow will increase and the body's blood flow decreases. And that's how he survives with the intact neurofunction, is what we need to appreciate. A young obese woman with oligomenorrhea with hirsutism with the ultrasound showing polycystic ovaries with granulosa cell marker is elevated. It is the anti-Mullerian hormone produced by the granulosa cells of the antral follicles, which are typically increased. A child with Prader-Willi syndrome typically has genomic imprinting, hypotonia, hyperphagia, obesity, developmental delay. So absence of paternally expressed gene at 15th chromosome Q11 is due to genomic imprinting is what you need to basically remember. After an unplanned excision of a deep thigh sarcoma, what is the next step? You need to do wide re-excision, removing the prior scar and biopsy tract, assess the margins and plan the adjuvant therapy is considered to be the management of choice. Neonatal HSV, the risk is highest in primary maternal infection. The primary maternal HSV infection, high viral shedding, no pre-existing maternal immunoglobulins of the IgG type, which normally go to the baby, and the intrapartum exposure during delivery will lead to high risk of neonatal herpes simplex virus. You need to remember, between IgM and IgG, it is the IgG that goes to the baby and offers the protection. Unilateral parapharyngeal mass with ipsilateral meiosis and ptosis on CT. Typically, meiosis plus ptosis point to the post-styloid compartment. It contains the sympathetic chain, hence Horner syndrome, and that lead to meiosis and ptosis on the same side. So that is a important clue. The small town lacks age-specific rates. So it is the indirect standardization. When no age-specific rates are there, we apply the standard age-specific rates which are already available to the study population and calculate the expected deaths. That's called indirect standardization is what you need to remember. So direct versus indirect, what is meant by standard population? Everything, I leave the literature to you in the PDF that I have sent to you. A pre-eclamptic woman who is on MoCK sulfate infusion develops a respiratory rate of 8 per minute and absent reflexes. What do you want to do? So any respiratory rate which is decreased, less than 12, absent DTR, decreased urine output, loss of consciousness, hypotension, cardiac arrest, they're all the important clues to say there is a MoCK sulfate toxicity is what you should remember. In ischemic stroke, who is a candidate for IV TPA, what is the pre-treatment BP value? It should be less than 185 by 110 millimeters of mercury is what you should remember. Now, how much 3% NaCl is required to treat hypernatremia management? See, it's very simple. Whenever there is a hyponatremia, per day you can increase the serum sodium value by 8 milliequivalents per liter. So, if you look at 3% NaCl, there is 513 milliequivalents per liter. So, based on that, you get the calculation very clearly, right? 3% NaCl is equal to 513 milliequivalents, whereas normal saline 0.9%. Typically, it will provide 154 milliequivalents per liter is what we should remember, right? Now, there's a marked weakness of the external rotation with a positive Hornblower sign. Arm abducted 90 degrees, elbow flexed 90 degrees. He will resist external rotation, and inability to maintain the external rotation or the arm which is dropping is a positive Hornblower sign, is a specific sign of the teres minor dysfunction is what you need to basically remember. Among the common nerve agents, which is fastest acetylcholinester is aging, making oximes useless. Which agent is it? It is Soman. Soman causes the fastest aging of the cholinesterase, and giving pralidoxim is ineffective if at all the poisoning is due to Soman. So Tabun, Serine, Soman, they are the major nerve agents is what we need to remember. So I leave the literature for you. Malathion, parathion, etc. And how do they differ? So in a diabetic who has non-healing medial malleolus ulcer and ankle brachial index of 1.4, what is the best thing you can do? You need to do toe pressure measurement. Right? Toe pressure before any compression. So, golden rule, if ABI is more than 1.3, you need to suppress, you need to suspect non-compressible arteries due to peripheral vascular disease, which is very common in the diabetic individuals. 18-week gestation, triploid 69 XXY molar changes. So, what is the most important reason? It is the dispermy 69XX or 69 XXX is caused by dispermy, two sperms. And a complete mole has no fetal tissue. It is all androgenetic in origin is what you need to remember. Once more, molar pregnancy, partial and complete mole is the favorite question of the examiner. A 60 kg with sodium 115 millimoles, seizures, how much 3% NaCl is needed to rise by 4 millimoles per liter? So, 0.6, that is 60% of the body weight is total body water. So 60 kg means 16 to 0.6 is 36 liters. Per each liter, you want to increase 4 millimoles. So 36 into 4 is equivalent to nearly 120 plus millimoles you need to give. And 1 liter gives 514. And 375 ml will give you that required number of millimoles. First, you need to calculate how many millimoles are required. So that is how the calculation is done. All right, doc. Now, whenever there's a subglottic carcinoma with clinically no neck nodes, the next best management is you need to do ipsilateral neck dissection and level 2 to 4 need to be remembered. Need to be removed. T1, T2, T2 and N0. That is the treatment modality. So once more, carcinoma, glottic, supraglottic carcinoma, based upon the stage, what is the treatment is a favorite question of the examiner. So, doctor, with this, today's full-scale grand test discussion, I leave the PDF containing all the 200 questions and explanations to you for you to do a rapid revision and learn 10 points on each MCQ. So good luck and look forward to see you all.